Without further ado, I am so pleased to hand this off to Jason and Sandy, and I'm sorry I forgot your name.
Elle.
And Elle, who I just met this morning. They're going to talk to us about the biopsychosocial workforce. This is going to be really, really interesting and really challenging. So, gentlemen, gentlelady, the floor is yours.
All right, thank you. Why don't we introduce ourselves first? I'm Sandy Blount. I'm the president of Integrated Primary Care Incorporated and professor emeritus of family medicine at the UMass Medical School.
I'm Jason Herndon. I'm a licensed psychologist, and I am the senior manager for care training for an online health company called Brightline. And three months and 3 weeks ago, I was the director of the UNC Greensboro Psychology Clinic, which is a graduate training clinic connected to the clinical psychology program there.
And I'm Elle Markman. I am also a licensed clinical psychologist and the co-director of One Medical Senior Health Integrated Behavioral Health Program.
So let's get started.
Let's do it.
And magically, it came up. Oh, it's over here. I'm going to just screw up here for a while, if you don't mind, until it's settled down and actually get going, because I'm really, really nervous. So that's our disclosure. We sort of just said those things. We have learning objectives, whichever. And if you don't mind, I'm not going to read them to you. If you are doing the evaluation, I hope you'll look at them later and see if we met them. So we're going to talk about rethinking the primary care team. And what we're going to say to many people here is not new to them. And we heard a number of ideas yesterday that are very much right on the track that we're going to be talking about. But I want to remind you of what a change this is in the conception of the team. There was the initial conception back in the day was influenced very much by the biopsychosocial model. And the idea was that there's a bio team member, that would be the physician or nurse practitioner, the PCP, and there was a psychosocial team member, that would be the behavioral health team member, and that was the new team. That was the hottest thing, and that was the thing that we were all passionate about. I think what we know now is that that idea seriously understates or underrealizes the impact of people's lives, the conditions of people's lives on their health. And so we're going to be talking today about the third member of the team that we're going to call, at least for the moment, the social member of the team. And we're going to be relating this to equity and to the idea that all, I believe, of the folks in here accept and promote, which is that one step toward equity is for people of underserved groups to be able to go to their healthcare team and to be likely to find someone that shares their life experience, that identifies with their group as one of the providers on the team. And there's been a way that we've been trying to do that all along, which had to do with how do we get members of diverse populations to be able to be members of the team by helping them get through the academic pathway that they need in order to be part of the healthcare team. And we've made some progress there, and there's still challenges there, and Jason's going to talk about that. But the other way that we want to talk about is how could we possibly build a pathway so that members of diverse groups could enter the workforce in the healthcare team based on their ability to relate to to patients and their experience in their community and the connection of their experience to be able to engage patients from diverse groups. And so here's Jason to start.
Thank you. Morning, everybody. Thank you for coming. So as we begin thinking about building the psychological workforce, right, we know that behavioral health providers are essential to integrated primary care. This is true across all of our integrated care models. I want to call out that efforts to diversify graduate education, particularly at the doctoral level, not because the doctoral level is super special, but because we tend to have the most work to do, particularly as it relates to representational diversity at the doctoral level. Those programs are essential, those efforts are essential, and they have to continue. Today, I want to talk a little bit about some of the additional areas of equity that we can grow. Ultimately, the idea is what we want is for BHPs to have consistent and equitable access to meaningful didactic and practicum experiences at the graduate level, because we think that this will help them be better prepared, more effectively prepared to step into the integrated care workforce as we move forward. There are really three areas of growth that I'd like to talk about today, not because this is the end-all be-all, but because this is the time that we have. One is around what we think about in terms of meaningful practicum experiences and some of the barriers that we see there at times. One is around everybody's favorite problem, funding, right, for programs and for students. And then I also want to spend a little time thinking about sort of additional areas that we could work in faculty development and additional areas of support. So when we think about meaningful practicum experiences, the primary issue tends to be that there can be limited or variable access to training opportunities that are available, supervised, and integrated. And so when I think about available, some of us, many of us perhaps, have seen or been in situations where it's hard to find opportunities to place practicum students where they would get actual hands-on experience at the graduate level. Sometimes this is because of an unwillingness or worry at the clinical site level of workload, right? How well trained are these students who are coming in? What is the amount of work that we will need to do to get them up to speed? How long will they be here in terms of the practicum length, but also are we talking a day a week? Are we talking a couple of days a week? What will that look like? And so there's actually a little typo here. The APA Division 38 course actually can help somewhat with this, and I'll sort of talk in a second about how. One of the ways I think that that can be useful is if we have broader dissemination, not just of the Division 38 course, but also some of the other ideas that we've heard already this week around how are we training our graduate students, that type of thing. If we have more visibility there around what those experiences are, I believe that that might help some of these sites have a clearer sense of, okay, this is the level of training that we have coming in. Another issue we run into is around accreditation. Accreditation within graduate programs is often going to require discipline-specific supervision. If I am a psychology trainee, I need to be supervised by a psychologist. If I am a social work trainee, I'm supposed to be supervised by a social worker. And so that can create issues around how do we have eligible hours for supervision that are connected to our accreditation, that are connected to graduation timelines, and that type of thing. A solution that we used at UNC Greensboro that has pros and cons is to do program-based supervision. I think other folks have tried this as well, where maybe I supervise some of our practicum students as their psychology supervisor, and then they might have an on-site supervisor who is of a different discipline there and is doing the work at the practicum setting. I think one of the concerns there is we need to make sure that the people who are doing that supervision are trained to do supervision, right? Both on the faculty side and also on the site side. I think the last thing, and we heard this come up yesterday, is the idea that, willingness isn't readiness, right? And so this is sort of practicum spaces on the other side of the spectrum. which is some people love the idea of having graduate students come into their place to work with them and to do fun things and cool things. But if they don't have a lot of sense of what integration actually entails, right, then how meaningful is that experience for graduate students, right? Graduate students having the experience of routinely answering the question, who are you and what are you doing here, is not super useful, right, in sort of moving them along the spectrum, though many of us have had that experience in our training. Funding limitations, I laugh because funding limitations are the perennial issue, right? And so of course what we want is for funding to be equitable and sustainable, right? And so I think a part of the thing that I want to say as it relates to equity is that practicum placements should be funded, all of them, every single one of them. And I will say that again, right? It's early, right? In case you didn't hear me, right? Practicum placements should be funded, all of them, because practicum placements without stipends privilege students who have more financial means. Maybe you have a spouse who has what we like to refer to as a real job in the graduate education world, right? Maybe your family, right, has more financial resources that they're happy to provide for you. It just creates this lack of equity. We've had experiences where we have places that would be meaningful training experiences, but they aren't willing to pay a stipend, and then we have to have difficult conversations around which of our students get to go there, right? And that just, again, right, creates this sort of issue around this equity piece. I think in addition, there's the scarcity of funding, right? And I'm going to talk about graduate or grant level funding in a second. The scarcity of funding can at times reinforce silos and territorialism, right? Organizations that have lobbyists tend to advocate for themselves, right? Psychology needs money to do psychology stuff. Social work needs money to do social work stuff, nursing, so on and so forth, right? And ultimately what that does is it shrinks the flexibility, right, of what we can do with the funding that we are receiving, right, which can have a downstream impact on team-based care. The last thing I want to call out for the operators in the room, programs don't develop or administer themselves. I don't know where the idea that they did comes from exactly, and they certainly don't develop themselves or administer themselves for free, right? And so another issue that we run into is, let's say we have a very willing system who wants to take a practicum student. They aren't as far along in terms of integration and knowledge as we can. They could really benefit and are open to some program development. That takes labor. It takes resources, it takes time and energy, and there is little of all of those things, labor, time and energy, and resources to go around, particularly at the graduate level. So quickly, for those who might not know, here are some of the most common HRSA funding mechanisms at the graduate level. There's the Graduate Psychology Education Program. There's the Behavioral Health Workforce Education and Training Program, or what you hear is BWET. And there's also a newer one. We heard about this one about 2 or so years ago and have recently sort of put it into place, called the Scholarships for Disadvantaged Students funding mechanism. I'm happy to answer questions about those to the extent that I can when we get to the question and answer period. Another important area for funding is the ability for graduate students to bill for the work that they are doing. Yes, absolutely. There's some optimism building, right? What we're hearing with the new HHS roadmap, what we're hearing on some proposed ideas at the Medicare level might begin to help us with this. Right now, it varies widely by state. One of the things that we're able to do in North Carolina is license our providers or our students at the master's level. So as a program, we paid for them to take the EPPP and then paid for them to get licensed and credentialed, and then that allowed us to take Medicaid both in the clinic and in some of the external practicum placements that we had. That would be a wonderful experience. There's a time issue there, which is you need students who are around long enough to make that worth your while. I think that's harder to accomplish at like an internship or a practicum level because you're there for such a shorter period of time. The second way that this looks is often I, as a supervisor, am licensed and credentialed with whatever insurance company you're interested in, and then the students who are under me can bill under my credential. That, as a more widespread opportunity, I think makes a lot more sense. And is a lot more applicable to other levels of mental health training. So I want to say that I think that faculty get some of the least amount of attention, right, when we're thinking about spreading out integrated primary care or scaling integrated primary care. So training in integrated care should be competent and comprehensive. That's what we're looking for. The push for integrated care, again, rarely extends to graduate faculty development, right? And so one of my personal pet peeves is when we hear something amazing at a conference like this one, it's new and it's awesome and we should be teaching people how to do it because it changes lives. My question is always, great, who is training people to do this? We're all done with graduate school, right? Or many of us are done with graduate school. We didn't learn it. How will we teach others how to do it effectively, right? And so an area for growth here is training for trainers, right? How do we think about that? I think that there are a lot of programs that I've heard that in my mind made me think, oh, actually, I think we could definitely apply that to working with folks at the faculty level. Dedicated coursework, of course, is essential at the graduate level so that we can have something more comprehensive. Practicum placements are wonderful and they should be plentiful and abound. And at the same time, we want to make sure that people are getting coursework at the graduate level that helps them prepare for integration and integrated care broadly defined. Again, I'll shout out APA Division 38's Integrated Primary Care Psychology curriculum here. For those who don't know, it is a prepackaged and, to my knowledge, freely available curriculum. It has several modules and also some supplemental modules that you can adopt into your graduate training program to teach as a standalone course. Other people have also used it in more of a modular way to sort of put some of the modules in existing courses, right, if you wanted to spread out sort of the teaching of integration across the curriculum that you already have. Again, I think it's important to call out that accreditation, graduation timelines, program requirements, and an unwillingness sometimes at the faculty level create barriers to new training foci. This is broadly defined, but we're speaking about integrated healthcare here specifically, right? When I say unwillingness, I think what we have to remember and keep in mind is that graduate training as it is set up at this point from the faculty level is largely a depth of expertise kind of a model, right? You spend a bajillion years, right, learning a handful of things very, 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 very well, and you are not very incentivized, right, to move beyond that or to expand out your area of expertise. How does that help your mentorship of the students that you brought into your program? How does, where's the resources and the funding to do that? And so we just need to be aware of that. Very recently, we had in 2021 a Barenbaum et al. Article come out where he sort of proposed this idea, he and his colleagues proposed this idea of really spreading out or changing how we do graduate training, particularly at the doctoral level. His argument is that there should be a 6-year system. 3 years are sort of basic coursework and therapy training, and the other 3 years are all dedicated to applied practicum and experiential experiences. We'll go with that. It's early, right? I think that this is a really interesting idea. There are pros and cons, of course, and this is a far away solution, right? Like this is not something that we will see within the next couple of years. And so I do think that there's more room for thinking around how we can support faculty, but also move some of these training experiences outside of academia altogether. So when I think about scaling the behavioral workforce, right, I think ultimately these limitations, right, again, inhibit our ability to scale this effectively. And at the same time, I think in many ways we're putting an over-reliance on our graduate education programs to do sort of all of the training lift or the vast majority of the training lift. That's a challenging ask because those systems can be fairly inflexible, right, by design. Lastly, I think the way forward, of course, is integration, right, both in the clinic, right, but also at a systems level, right, team-based care and collaboration like we do here. This is the way forward in how we think about how do we pull in all of the interested parties to figure out how do we help graduate level education get us where we're trying to go. We're going to hear from Sandy a bit to talk about some of these additional team members that we might want to add.
Thank you.
Yeah.
Thanks. So we've been hearing about the academia leads to practice approach, the only approach often that people consider. But I'd like to, and we would like to suggest maybe there's another approach in which experience and training and practice lead to growth that's augmented and supported by academia. But let's start with talking about the evidence. There's actual evidence here for this third role we're talking about. And it is often called an enhanced team in the studies that call for this person. And there are 3 fairly separate literatures that develop this evidence. One is a literature on what are called complex patients or high-utilizing patients. Another is a literature on what the literature calls disadvantaged patients, patients who come from low-income backgrounds, or patients who are, as a condition of their lives, enduring bias or racism. Just to remind you, how sick you are correlates with your income over your life. And the third literature is people who are talked about as trauma victims, people with PTSD symptoms, people with high ACEs scores if you're doing a screening. And it turns out that while each literature doesn't necessarily acknowledge this, at least in the research that I did for a book recently, what the groups tend to overlap so substantially that it's not crazy to say we're really talking about one group of folks. And so we might learn for each literature from the other. It wouldn't be crazy to say that people who are complex patients, people who are folks from low income who cope with trauma and racism, might benefit from trauma-informed care as a basic approach. And what is this extra team member supposed to do in the literature? Well, they're supposed to build relationships with patients that engage them in care and build relationships for the team with patients to increase the understanding and skill of the team in relation to these patients. They are supposed to offer guidance to these folks in accessing the greater medical team, and I use the word greater medical system, and I use that word greater advisedly. They help connect patients to community resources that are not part of the medical system, and they help support and educate patients to meet their health goals. So, who are these folks? Well, we did a study in New Hampshire I go back to half of my life, it was 1900. Way more than half. In 2018, and we were commissioned to study the behavioral health workforce in New Hampshire. And we surveyed the safety net clinics, the FQHCs and the rural health centers, and we got responses from 71% of those organizations. And what we learned that, at least in those organizations at that time, there were 64 behavioral health clinicians. There were 43 psychiatric clinicians, psychiatrists, NPs, and PAs. And there were 98 others. And so we asked these clinics, we said, well, how many will you need in 5 years? And they said, well, we're going to need another equal amount of behavioral health clinicians. It needs to grow by 100%. The psychiatric clinicians, they felt they were doing better on, only a third more. But these other folks, they wanted 120% of them. They were the folks that they were relying on for a great deal of what turns out to be behavioral type of services for patients. And the names of these folks, at least in New Hampshire, were health coach, navigator, patient advocate, patient educator, community health worker, care coordinator, care manager, peer counselor. And we asked the sites for the job descriptions of these people. And what we found was there was very little consistency across sites. So if you knew what a navigator did in one site, you did not necessarily know what a navigator did in the next site. And what were these members doing? Well, look at the list. It's the same one. They were helping engage patients in care and help the clinic engage with the patient. They were offering guidance in accessing the larger medical system. They were helping connect them to other community resources, and they were helping support and educate patients to meet their health goals. When we wanted to describe this group, we tried to stay away from what we thought of as brands, the health coach brand, the community health worker brand, both because we didn't know what people were doing. The name of the role didn't describe a consistent role, and because there were a lot of sort of folks pushing their brand, saying, look, we have evidence. When you add our brand of people, healthcare gets better. But the evidence tends to talk by role names rather than by functions. And so we got the idea that a great deal of this evidence was talking about similar functions with people with different names. So we call these folks care enhancers. It's not a great name, but it's clearly an umbrella name, and we didn't think it was going to catch on. So what are these care enhancers? What do they provide for primary care, and what does primary care provide for them? Well, they provide primary care, first of all, better care. They represent a step toward equity because members of populations that wouldn't have expected to find someone on the team who looked like them or who shared their life experience now could find those folks. They improve the diversity of the workforce, and when you improve the diversity of the workforce, you improve the care provided by the non-diverse folks as well. And they provided better engagement for the health center as a whole with the community that they were serving. What did care enhancers get? Well, first of all, they got a job in the hot new field called healthcare. And that job, in most settings, got them recognized and helped them recognize for themselves how their experience and how their ability to relate to patients was in fact an expertise set, just like the medical folks on the team have an expertise set, and the behavioral folks on the team have an expertise set. And as people began to recognize their own importance to the team, it tended to support confidence, support belonging, and help people raise their horizons in relation to their own careers. And so we proposed an approach for people to think about. We borrowed from nursing. Nursing has, for many years, had within the discipline the ability for someone who's an LPN to rise to be an RN, to rise to even be an NP, without leaving their setting, without having to give up their check. But this group we're talking about isn't one discipline. It's a hodgepodge. And so we were hoping to conceptually present this so that people could think about how we might do this better. So we're talking about entry levels that we call the community health worker, medical assistant, medical interpreter, and that by adding training, they can become patient advocates, health coaches, care managers, and care coordinators. And then as they grow, as they become, the experience with patients is such a powerful teacher. breeds expertise as people get at it, deep expertise, different from academia. And that then can be the basis for credentialing, programs where you can become a clinical social worker, a marriage and family therapist, mental health counselor, without leaving your check. And on the website, which is in the upper left, if you click on any of these boxes, it will take you, with a New Hampshire focus, to what's the definition of that role, where could you get the training to get that role, and how much do those folks make in 2018 in New Hampshire. Seems like this could be done for a lot of places. So what else is required? Well, when we first started introducing behavioral health into primary care, what else was required? Everything. We were a problem from the jump. And it'll be the same. We won't think about, or the system doesn't think about a career ladder for these folks, but so some of the things that might have to happen. Primary care will have to be much more acceptance of its role as a training site than currently. Primary care, there are obviously very many training sites, and we all have been to those, but there are a lot of practices that don't think of themselves as training sites. And if they are going to develop the workforce they need, they're going to have to step up. That it will take a competency approach to job definition and to payment, because the HR folks in a lot of places are going to already have very clear hierarchies of where the roles are, and that's going to have to become flexible. And health systems will need to participate in the programs that are training the entry-level folks. Something that I've seen in several sites has been that there's a community health worker training over at the community college, and they're turning out people which the primary care folks don't want. They don't fit. They haven't got the right skills because the training there is very general and to maybe go in a lot of directions. And so primary care folks are going to have to make liaison with these trainings or take it in their own health systems. And of course, there's going to have to be funding. These people are going to need to be able to hold on to their paycheck through the whole process of their training. So the companies will need to have internal training resources for their specific needs and how they define roles, and there will need to be funding for external training when people go outside the health system to get their credential or to add modular skills to what they do. And we're going to show you now a 4-minute video of people talking about exactly such a funding approach. In the one you're going to see, the money comes from the health systems, and it's part of the negotiation of the union with those systems. The points they make are going to be similar to the ones we've talked about, but it doesn't have to go that way. This funding could come from many different sources. So if you all would play the video.
We need healthcare workers desperately.
So we have to get creative and also do our part to build that workforce. I'm really proud that Kaiser Permanente has made this investment.
I had the privilege of joining the training fund over five or 6 years ago as a member representing Swedish. Each hospital contributes monies for growth and development of all our caregivers. Collectively, we make decisions about how we use the monies in the training fund. It's a think tank. You get to tackle some of the hardest issues and challenges facing healthcare. It's not only a recruitment strategy, but more importantly, it's a retention tool. The Training Fund offers support in a multitude of areas where we find that caregivers usually have barriers. We're exploring apprenticeships for a multitude of different service line and areas, looking on how we can increase workforce.
We've had early success with the apprenticeship model for medical assistants. We were able to develop a program that is comparable or superior to the traditional education. Most people need to work full-time and can't work full-time and go to school and don't have the time for that and take care of their families. So this is a way that we could support that education while they're on the job, being paid and doing the work. It has turned out to become one of the initiatives to support our equity, inclusion, and diversity goals.
Before I became Chief Quality Officer, I was a nurse. And before I was a nurse technician. And before that, I was a phlebotomist. And when I came to Swedish, I was able to use the monies provided by the training fund to go back for my graduate degree. And so I've benefited from the training fund. And likewise, there's countless stories of caregivers who have been able to expand in their professional development by going back to school.
This has been a shared purpose and a shared goal that we could collaborate on across so many different stakeholders.
You do better together. COVID-19 has definitely taught us that.
It's just a win for everyone.
Thank you. So now we'd like to give you an example. This is an example in one health system, a health system that has a great deal of commitment to training, of a creative use of the care enhancer role, which they call health coach, and of putting that person as the quarterback of the medical visit. But Elle Markman is going to tell you about how that works.
All right. So before diving in and talking in detail about our care enhancer role or the health coach role at One Medical, I want to start out with just a little bit of background on One Medical Senior Health. So we provide comprehensive primary care to adults on Medicare, primarily, although not exclusively, older adults. And we operate in a value-based care model, which represents this broader transformational shift in the healthcare industry, away from incentivizing volume of care and instead toward incentivizing value of care. And so what that means is providing the highest quality care at the lowest possible cost. And so as a healthcare system, we assume risk for the healthcare outcomes of all of our patients, which gives us the incentive really to do what is best for all of our patients and gives us the flexibility to be creative about how we do that. And that is reflected in how we think about our model of care and in how we think about our care team. Now, any of you who work in the Medicare population can understand kind of the challenges of navigating the realities of high costs and the complexities of this population, and for a vastly and very quickly growing population of older adults in the United States. And in order to successfully provide high quality, low cost care, we have to think about population health, which I know is a topic that's already come up quite a bit in some of our sessions. And we have to think about how to provide care in a sustainable and equitable way to all of our patients. Now, One Medical Senior Health is doing that in a lot of ways, but I'm going to focus in today on two kind of key features of our care model that stand out. One is this idea of deeply integrated behavioral health care. So we talk a lot about primary care behavioral health, and we think creatively about how to extend that integrated behavioral health care beyond just the care team, beyond just the direct patient care, but instead to every aspect of our company model and of leadership and of our operations as a clinic. So we'll talk a bit about that. And then in providing this population-based care to our patients, we've identified a gap. We've identified, as we've talked about today, an opportunity to really think creatively about filling this missing role in partnering with our patients in order to be most effective in reaching all of our patients in the way that they want to be reached. And so we'll talk a little bit about that role today, that care enhancer role, which at One Medical we call the health coach. So first I'm going to start with just a very broad, brief overview of our integrated behavioral health program and the behavioral health specialist role, which many of you know as the behavioral health consultant, or the BHC. So we have a couple of our wonderful behavioral health specialists here today, so shout out to them. And I can say that I could spend another whole hour, 2 hours, just talking about our integrated behavioral health program, but I will just try to keep it quick for now so we can get more into the health coach role. So we operate largely in a primary care behavioral health model, which many, if not all of you, are somewhat familiar with. But again, so in terms of what that looks like, about half of our time is spent in direct patient care, warm handoffs, same day, next day, open access for our patients. And then the remainder of our time, we're thinking about how we can impact all of our patients beyond that 25% of our panel that we might have in direct patient care encounters. So that means this deep care team integration. We huddle with our teams every morning. We panel round with our teams, particularly talking about our highest concern patients. We spend a lot of our time in teaching and training, which we'll talk a little bit more about. And we talk about how to have the behavioral health voice in the day-to-day operations of our clinics, of our markets, and in our company as a whole. So we're talking about problem solving, we're talking about process improvement. Now, a lot of our time and a lot of our focus goes into our highest risk patient support. And so for One Medical Senior Health, what that means oftentimes is our patients who have had multiple admissions, readmissions, our solo seniors, folks that are either living alone or have a minimal social support network. We're talking a lot about our patients who've had new diagnoses of dementia, cancer, COPD, diabetes. And we're making it a point to have a dual focus on both our kind of bread and butter behavioral health conditions and our chronic medical conditions. So we're constantly thinking of ways to partner with the rest of our care team to impact chronic disease management, patients with diabetes, patients with uncontrolled hypertension. How can we have that behavioral health integration and voice for all of our patients in every domain? And the common through line through all of this is thinking about measurable impact, not just with the patient who's sitting in front of us in the room, either virtually or in person, but all of our patients. Are we impacting our value-based care model in the way that we want to, in the best way that we can? Are we helping our care team to meet our goals of reducing healthcare costs and providing the highest quality of care? And so because all of this is on our minds, we think of our program not just as an integrated behavioral health program, but as a population health program. And so to take a look at why this is so important, we have a team of about 35 behavioral health specialists, and we have a panel of about 60,000 patients. So if you look at this, many of our behavioral health specialists are covering one larger clinic or potentially 2 or more clinics in more of our small emerging markets. So we might be working with 3, 4, 5, 6 PCPs, and in turn, each one of those PCPs might be working with 2 or 3 health coaches. So when we think about meaningfully, sustainably, and equitably impacting all of our patients, that becomes much more feasible when we think about doing so through our health coaches, particularly when we think about growing from 60,000 patients to 600,000 patients or 6 million patients. And so this is why we think about our health coaches as an essential core member of our primary care behavioral health program. Okay, so now it's time to finally talk about the health coach. Who are our health coaches? The commonality in all of our health coaches is their empathy, their ability to build relationships, and their connection to the community we serve, their representation of the community we serve on our care teams. In terms of their education and training, that's highly variable, with some regulation and variability based on state, but overall, highly variable, no minimum requirements when it comes to education and training. We think of our health coaches as the bridge on our care team between the healthcare system and the community that we serve, our patients. They are the end-to-end visit leader during patient encounters and the patient advocate and champion outside of those encounters. So what that actually looks like is that our health coaches will go out to the front, greet our patients when they arrive, introduce themselves, bring them back, take their vitals, and go into an exam room, sit down with the patient, plug in their computer so that the patient's chart and the note they're creating starting the agenda is in front of both the patient and the health coach. Full transparency. Together they work on setting an agenda for that visit, asking the patient, what is important to you? What matters most to you? If it's a new patient, maybe spending more time just getting to know them. Asking them, what do you want from us today? What's important to you? What's your priority? And helping to kind of set expectations early on for that visit. All of that happening before the PCP even comes into the room. When the PCP comes into the room, the health coach completes a warm handoff with the PCP, transferring all of the knowledge and the relationship that has been built in the beginning of that visit, and in essence, transferring the trust from that early relationship between the health coach and the patient to the PCP. Throughout the rest of the visit, the health coach is scribing, taking notes, creating tasks, starting an after-visit summary as the PCP and the patient continue their conversation. Time to time jumping in and asking questions that potentially the patient is wondering about and not voicing for themselves. Challenging the PCP to better explain a concept that the patient has expressed they don't really understand. And all the while modeling respect and communication between a non-clinical care team member and a clinical care team member. And thus empowering patients to be their own non-clinical care team member, and in fact, a leader in their own care. And this is particularly important because many of the patients that we serve, previously their experience of healthcare has been very disempowering and disenfranchising. And this is an opportunity that we see to kind of recreate that healthcare partnership for the patient and re-invite them and re-empower them in their own care. Now you might be wondering, well, how is that possible for the health coach to be doing all of these things when there is no clear kind of set of expectations for them coming in the role in terms of their background and education? Well, we feel that in exchange for the roots in the community and the transfer of trust that the health coach is able to provide us on our care team and represent for us on the care team, we can in exchange transfer our knowledge and skills as clinical care team members and teach them these skills essential to their role through continuous cross-functional training on the job. So on the medical end of things, what that often looks like is how to take vitals, how to give a flu shot, what is hypertension, what is cancer, how can I have meaningful conversations as a health coach with the patient to help them understand, to provide some of that medical education between the two of us, and how can I set meaningful goals that contribute to the patient's individual health goals. On the behavioral health end of things, that often means how to set an agenda, how to have patient-centered communication in the room, how to set goals for the patient in terms of motivational interviewing, how to elicit from a patient what's important to them, how to set boundaries in a visit, how to set time expectations in a visit. And then on the other end of things, outside of the essential skills for the role, is this idea of self-directed professional development. Many of our health coaches come into this role knowing that they want to grow in certain areas of healthcare. Maybe that's nursing, maybe that's medical training, maybe that's behavioral health or healthcare management, public health. And others come in not really knowing, but they want to serve their community and they want to help people. And then they very quickly or over time learn on the job what's most interesting to them in their own professional development. And so we're able to further support them in the more advanced areas of their interest through involving them on work groups, projects, helping them take the lead on clinic initiatives in an area that's of interest to them, and helping to support their own self-directed professional trajectory from there. So many of our health coaches do go on to pursue higher education in nursing, medical school, behavioral health, public health, and many stay at One Medical and kind of grow in leadership within One Medical without leaving. So we have many health coaches who become care team managers or who transition to one of our central teams, learning in areas of network development, data analysis, patient enrollment. And so we have experienced this model so far as sort of a win-win-win. So it's a win for our patients because they are able to see themselves in their own care team and have this advocate and learn that they can be respected and communicated with as an equal in their care team. They can lead their own health. It's a win for our clinical team because we are anchored in learning about the community we serve. We are challenged to think not only about our own healthcare goals as a value-based care organization, but the patient's healthcare goals and how to align those two. And it's a win for our health coaches because they were able to come in and express what's interesting to them and be supported in their own professional development. So from here, I will hand it back over to Jason.
Can I add that we originally had a health coach on our team, but she got promoted and couldn't come.
That's right. That's right.
That's true.
So as we think about what's next, right, and then we're going to move into just a period of question and comments, really we're encouraging folks to begin thinking about ways to raise their profile within your various spaces and organizations of these care enhancers, sort of whatever it is that you call them, right, in your spaces. You want to begin to reassess the evidence on their impact, right, by function rather than job title, right? So it doesn't necessarily matter of health coach versus care navigator versus whatever, right? It's thinking about what are they doing and how do we sort of standardize that. It's thinking about building career ladders, right, with training so that people don't have to stop working to go out into the education, right, into academia, gather more training, that type of thing. How do we bring training in to various systems? How do we support training for systems that are smaller, right, and don't have the bandwidth to create their own internal training systems? I think we also want to think about how do we increase the presence in CFHA membership and at conferences, right, for folks in these various roles. I will say one thing that people might not know is that if you're coming from an organization that has an organizational license, or you have purchased an organizational license as a board member, I thank you, for your particular organization, anyone on your care team falls under that organizational license, right? So they are already members of CFHA, whether you or they realize it or not. And I think that there are additional things that we could probably do to have this conference be somewhere they want to come, right? Somewhere that makes sense for them. Right, especially considering they don't always have access to the types of additional financial support that some of us might have access to in terms of coming and presenting at conferences and that type of thing. So if you have questions, we're happy to take them now. Here are all of our email addresses. We'll keep this slide up. We also have, there should be a form that you can sign up for if you'd like to continue this conversation at some point, or if you'd like to lead this conversation. And so we'll make sure, there we go. So if you're interested in doing that and signing up, please do so. And then CFHA is happy to help facilitate that conversation from a virtual kind of a place, okay? Thank you all very much. Questions, comments?
We have the dual mics out there. Please use them.
Hi, I want to thank you for your presentation this morning. And really, not a question, but a shameless plug. I hope everyone doesn't forget about their AHECs. Every state has an area health education center, and I was lucky the last 5 years to spend half of my time working on building reverse integration clinics and the other half of my time running a workforce development program, a pipeline program through AHEC for high school kids that are interested in healthcare education. And so we spent 5 years working with high school youth, getting them excited about health careers. And so think about AHECs when we're thinking about these pipeline programs. Let's write some collaborative grants, because really AHEC, we're all about recruiting, training, and retaining the healthcare workforce, and trying to embed integration and behavioral health into that is a really exciting opportunity. So.
Thank you so much.
Thank you.
Hi, can you hear me?
Yes.
Hi, I just want to thank you for some of these wonderful ideas. I'm a professor in a MFT master's program, and we're embedded in a medical school, and our mission is to increase access for rural and underserved populations. So you hit all of the check boxes for me. I'm also from Georgia. Anybody else here from Georgia? Okay.
Go Dogs.
This is not like a stunt. I want to put a plug in for, Georgia has not traditionally been known for our mental health access treatment, but the state of Georgia in 2019 and 20 created a Behavioral Health Innovation and Reform Commission. And in the last 2 years, members from CFHA and AMFT have advocated, attended, and testified at these meetings in the hopes of advancing some of these issues of workforce. And one thing I thought I would add, I really connected with this idea of financial limitations limiting the diversity of our graduate level workforce. So in Georgia, last year they passed the Mental Health Parity Act. And embedded in that act is loan forgiveness from mental health providers in Georgia. And I think that is an amazing opportunity or option for folks in this room, is to advocate at that state level for programs that can really speed up the process of helping folks stay in and get into that behavioral health workforce. Just another plug.
Yes,
and
absolutely.
To work with AMFT and the LPCs and the social work organizations at the state level who are already advocating for those things as well. So thank you for your work.
Of course. Yeah. Thank you.
Good morning. My name is Rachel. I'm also from the South, sort of in North Carolina. So thank you.
Southish.
Yes. So I wanted to actually chat with you, Greensboro person. Anyway, I'm working in Charlotte at an FQHC. And my questions are a little bit logistical about the health coach role. So the first is, does this role replace an MA? And if not, how do the two of them work together? My second question is if you work, Elle, with any non-English speakers, and if so, how do you build the quick rapport through translating services? And my third is just a question, is there an auxiliary benefit here to the patient not being left alone in their exam room? Do you see that they often have someone like physically proximity with them throughout their entire appointment? So those are my questions. Thank you.
Yeah, okay. I'll take them one at a time and hopefully remember, but I might need you all to remind me. Part one, we do not have MAs. So yes, they replace the MA role, and a lot of the work, several of our health coaches come in with MA experience and have that skill set already. Others do not, and that is part of what we will supplement with that continuous training to be able to teach them anything we need that's kind of related to that MA role. Secondly, yes, we have a large number of a portion of our population speaks languages primarily or preferred other than English, largely Spanish-speaking population. We make it a point for our health coaches to represent the population we serve, including language barriers. And so we work very hard to have our health coaches in a market with predominantly serving Spanish speakers represent and speak Spanish in the room, and then translate potentially for any provider who does not speak Spanish, but that predominantly the language exchange is in the patient's preferred language. And then third question.
Just about time spent alone.
Yes, thank you. That certainly some of the feedback we've heard is that from a patient experience standpoint, that can be a very powerful presence just to have somebody remain in the encounter with the patient, particularly if they're alone, which many of our patients are and are used to being in a waiting room, potentially alone for many minutes of their visit, to be able to use that time instead for that relationship building and continued conversation, even if it's not directly related to the agenda or health goals, have that be an opportunity to get to know each other and really build that rapport and build that trust.
Awesome, thank you so much.
And I would add that the health coaches have specific panels each. And so they are also the outreach to those folks between visits. And occasionally people will come in for a health coach visit without necessarily seeing a medical provider.
Yeah, thank you for that call out. I didn't even mention that, I meant to. But yes, we do often have health coach only visits, again, where there's that continuation of relationship building and working towards the patient's individual health goals without a PCP even needing to be part of that visit at all.
Good morning.
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 I'm Bill O'Connell from the University of Washington, and pleasure to be here. And I'm a former colleague of Elle's, actually, and the health coaches, to me, were just amazing in terms of their relationship building with patients. And I was fortunate to work at a clinic with health coaches who identified as BIPOC, all of the health coaches that I worked with, and also several were multilingual. And I could not have done my job without them. So their ability to bridge behavioral health with patient care was extraordinary. But they were also very experienced. So some of those health coaches are still there. They've been there for 7 years or more. So you think about the length of time that they're with patients, even when providers change, they're a constant in many cases. But the health coaches inspired me because they often asked, how can we do a better job of addressing the behavioral health issues with our patients? So I did choose to leave the organization that Elle and I were a part of, and I'm working on a project to build capacity in the state of Washington to train bachelor level support specialists for behavioral health. So this would be an opportunity for a psychology, social work, or other human service program to train or integrate curriculum that would prepare people to work as support specialists delivering interventions. And I'll talk about that later today if you want to look me up on your app.
Oh.
But, one of the things that's interesting about it is the biggest opposition to it is coming not from integrated care, but from specialty mental health. So the concern specifically is that if we have bachelor level people who have skills and they're trained to work in integrated care, that's going to draw away the workforce from specialty mental health. Now, this is where I think it gets tricky, is the argument that's being used, and they're giving this argument to legislators as well, is that primary care is more attractive because the patients are easier to work with. So
that has not been my experience.
So I'm
they
just
get better
curious.
faster, but
Right.
I'm just curious in building this idea for care enhancer or expanding workforce and integrated care. How do we also continue to collaborate? Because specialty mental health is important, and I was a part of that world also and want to support it. But deal with some of these myths, if you will, that get put out there about what happens in primary care and who we're actually serving and the impact that we have. How can we do a better job of communicating to our colleagues in specialty mental health, but also to the public about what happens in primary care?
You have an idea?
how can we communicate better with specialty care?
Yeah. And the public.
And what?
And the public.
And the public. About integrated care?
Uh-huh.
We're doing great. I mean, how could it be better? The problem with integrated care that I find is that it makes so much sense to everybody except the professionals. If sitting next to somebody on a plane and you're talking to them about what you do, and you say, yeah, I'm a psychologist, but I actually work in primary care because so many people come in and their stress is part of how they develop their illness, or they're depressed as well as drinking too much, as well as not taking their medicine. And so I'm there to help the doctors and other folks and the patient work together better. And people say, duh, well, of course. And then they say, well, why don't I get that? And actually, that's why the term integrated care came. That originally, back in the day, everybody's talking about collaborative care, not COCM, way before that. But we were talking about collaborative care because we were so interested in the relation of the professionals.
Right.
And it seemed to me that that's not the patient's interest. The patient's interest is in a service that's going to fit for me. And so integrated primary care, I thought, would be something that people could ask for, could demand. And so that's how that term came to be.
I also think I would say that one of the things that, I haven't said anything radical yet, so I want to say this. I think that we, as the field of psychology, spend a great deal of time trying to keep others off of what we see as our land instead of defining what it is that makes us unique and useful within the team-based care, right? And I think that that's more of a problem for us as psychologists, right? And less of a problem for people who are not psychologists, right? And I'm probably preaching to the choir in some way in this, with this comment, but I think that's a part of this too, is particularly in specialty mental health care, there could just be so much like, no, nobody else can do any of this, as though all of the work and time and energy it takes to grow a doctoral level psychologist exists in a vacuum, right? So how are we going to scale to meet the demand that we're already falling behind to meet if we're keeping any and everybody who's interested in helping meet the need of our populations outside of the gate?
Can I say one more thing about relating to specialty care? In our practice, in our health system, we happen to be blessed with a lot of specialty mental health services in Worcester, Mass. And we had a terrible time connecting with these folks. And so we sent one of our most engaging trainees out. And we said to her, you get to know the intake worker at every one of these places, and you better come back knowing whether she likes being in Worcester or not, and whether her kids are doing fine in the school system, and what she hopes for in her future. And if you have to buy her lunch, buy her lunch. And after that, we could get our patients seen, and we got them seen quickly, but we had to say that we were friends of this person to me, because it's on relationship. Isn't that amazing? It's about relationship. All right.
Hi.
Yeah.
Okay. How much do you pay those health coaches? Sorry.
Not enough.
Not
in my
enough.
opinion.
Okay. Do you have any like teen clinics or youth clinics and use teenagers as health coaches? No? No? Okay. I'm just curious. It just popped in my head as we're working with youth in different areas that want to engage and help educate other youth. But thank you.
I love that idea. Yeah. Somebody note it on our team.
Wow, that was fantastic. I want to do a quick poll of the room. Would you all feel good and feel like it would be a right thing for this room to have a bunch of care enhancers here sitting with us? Yeah? Yeah, feel? All right. Well, let's collectively work on that. Let's figure out some ways. We have to think about some ways here at CFHA to think about that, right? But you all too. Think about ways if you're starting these programs or bring them into the fold. And that means we would need to have sessions that would be attractive to them, right? And we would need to have, make this a home for them just as much as it is for licensed professionals, right? So let's kind of think about that together as a community. I suspect that that's going to happen because that's the way we do things here at CFHA, right? From this. This has been a great session. Can we give these great folks a round of applause here?
Thank you. Thank you.
Yeah. I don't know if I speak for other folks, but I've heard about health coaches and peer support specialists and all this for a long time in my career. And something about the way you all put it together today, and Ellen, you're a very pragmatic, real-world exemplar, just put it together for me in a way that I had not considered before. So thank you. You have, I think, expanded our definition of the care team in a way that's substantial. Folks, have a great rest of your day. Again, if you want to interact with Sandy and the rest of the folks here, that QR code is up there. Yeah, we'll say thank you to these folks at the other plenary, Liana, so we'll put up that slide later. But we'll keep this up. Have a great rest of your day, folks.